So good morning everybody. So today's lecture will be on infective endocarditis. I have been referring to this disease quite frequently in the previous classes on cardiovascular diseases, infective endocarditis. So let us go into some more details into this particular disease today. So it is basically a microbial infection, predominantly by bacteria and also by sometimes by fungus and other atypical organisms, affecting the heart valves and the endocardium, the lining of the cardiac chamber, or the blood vessels. That means the endothelium layer of the big blood vessels, and it may also affect congenital anomalies. It may affect also the native valves, that is the normal valves, and also the implanted valves. The prosthetic valves may be affected. Either of them may be affected here. So how do we classify them into different types? So endocarditis can be classified according to the temporal evolution of the disease. That means how rapidly it has been developing, depending upon the site of infection, then what causes the infection, and whether there is any precipitating risk factors giving rise to the infective endocarditis, like injection or intravenous drug users, or whether it is associated with healthcare associated infection. Well, depending upon the temporal evolution of the disease, we have basically two clinical entities. One is subacute endocarditis, previously also known as subacute bacterial endocarditis, which is a much more commoner variety, and an acute endocarditis. Now, acute endocarditis is a very hectically developing febrile illness that rapidly damages the cardiac structures and goes on into extracardiac sites, and if untreated, progresses to death within weeks. The subacute variety goes with an indolent course, causes structural cardiac damage very slowly, and it does not metastasize or spread so quickly like the acute, and is a gradually progressive disease unless it is complicated by some of its own complications like an embolic event or rupture of a myocardic aneurysm. Some of the predisposing factors for infective endocarditis are congenital heart diseases, rheumatic heart disease, intravenous drug use, degenerative valve disease like sclerotic atherosclerotic valve, intracardiac devices, or implanted prosthesis. It's not a very common disease. In the community, it ranges between 5 to 15 cases per 100,000 per year, and most of the time it is a disease of the elderly. In one British study, they have found that the underlying etiology is rheumatic heart disease in about 1/4, followed by congenital heart disease, and other abnormalities like a calcific aortic valve or a mitral valve prolapse in another 25%, and pre-existing cardiac abnormalities in 32%. So these are almost equally divided between the different types of diseases, either rheumatic or a congenital or a structural abnormality or pre-existing cardiac abnormality. The case fatality is about 20% even with treatment, and it is higher in patients with prosthetic valve endocarditis and those infected with antibiotic-resistant organisms. The pathophysiology of the disease, it typically occurs at sites of pre-existing endocardial damage, usually. But infection with virulent or aggressive organisms like Staphylococcus aureus can cause endocarditis in normal valves and not in the normal valves. So in acute endocarditis by a virulent organism, sometimes we find that a normal valve is affected by a very virulent organism. Then staphylococcal endocarditis of the tricuspid valve is a common complication of IV drug use. Many acquired and congenital cardiac lesions are vulnerable, particularly areas of endocardial damage caused by a high pressure jet flow by the blood, like in ventricular septal defect or in mitral regurgitation and aortic regurgitation. And in many of these, the primary lesion may be hemodynamically insignificant. In spite of that, the infective endocarditis may have developed in these. And in case of hemodynamically low pressure lesions, like in atrial septal defect or mitral stenosis, the risk of endocarditis is less or almost minimal. So in these diseases, infective endocarditis usually do not occur. The infection occurs at sites of endothelial damage by attaching deposits of platelet and fibrin. So the first focus is deposition of platelet and fibrin at the site of injury, followed by bacterial colonization from the organisms which are already in the blood. Now these avascular areas of the tissue, along with fibrin and platelets, protects these particular organisms from the inflowing blood and the antibodies flowing in the blood. That means from the defense mechanisms of the body, these organisms are protected so that the organisms can grow. And these vegetations, which are basically formed by the fibrin platelet aggregation along with bacterial colonization, may form two problems. One, they may obstruct the particular orifice, that is the valve, or they may break down and go to a distant site and embolize. And thirdly, they may also destroy that particular area of the tissue, producing breakdown of that valve. Now, valve regurgitation may develop or increase if the affected valve is damaged by tissue disruption, cusp perforation, or disruption of the chordae. There are also extracardiac manifestations, including vasculitis, certain skin lesions, either due to the emboli or due to immune complex deposition. Then the area of mycotic aneurysms may develop in the arteries if there is endarteritis at the site of infected emboli. In fatal cases, infarction of the spleen and kidney and also immune-mediated glomerulonephritis are found. What are the causative organisms? Streptococci, mainly Streptococcus viridans, and certain staphylococci are found in more than 75% of the cases. That means majority of them are by these two groups of organisms. In the subacute bacterial endocarditis variety, the causative organism is Streptococcus viridans, like Streptococcus mitis and sanguis, which are usual commensals of the oral cavity, which enter the bloodstream by minor injury into the oral cavity, like during chewing or while brushing the teeth or during some minor dental procedures. And this leads to the disease of subacute bacterial endocarditis. Now, other organisms like Enterococcus faecalis, Enterococcus faecium, and Streptococcus gallolyticus may also enter the bloodstream from either the gut or from the urinary tract. So, the organisms can enter the blood either from the oral commensals, as in Streptococci viridans, or from the urinary tract or from the gastrointestinal tract, either by Enterococcus faecalis from the genitourinary tract or Streptococcus gallolyticus from the gut. Now, patients having endocarditis by Streptococcus gallolyticus should always undergo a colonoscopy because this organism is commonly associated with malignancies of the large gut. Now, the microbiology of acute infective endocarditis. The common organisms are Streptococcus aureus, Streptococcus pneumoniae, and Streptococcus pyogenes. Staphylococcus aureus, Streptococcus pneumoniae, and Streptococcus pyogenes. Now, Staphylococcus aureus is the most common cause of acute endocarditis, and it is a common commensal of the skin. Usually, it comes from the normal skin, from abscess or vascular excesses, like a site of the IV line, or in persons who are intravenous drug users. It is a highly virulent and invasive organism and produce florid vegetations and also occurs in normal valves and causes rapid destruction of the valves with abscess formation. Then there is another variant, post-operative endocarditis. Usually occurs after cardiac surgery and may affect the native valve or the prosthetic valve or other prosthetic materials of the put inside the heart, like a catheter. The most common organisms being coagulase negative staphylococci, like epidermis, which is a part of the skin. Well, this organism can also cause endocarditis of a normal valve or a native valve, irrespective of surgery. So that has to be kept in mind. Staphylococcus lugdunensis, which rapidly destructive acute endocarditis in previously normal valve. Now, the important thing regarding these organisms, either Staphylococcus epidermidis or the second organism, whenever you do a culture for this particular disease, a blood culture, and you find that these organisms are growing, most of the time the clinicians try to ignore them as contaminations of the blood culture. But sometimes these may be the causative organisms even in a patient with infective endocarditis occurring in a native valve, that means without a history of surgery. So that has to be kept in mind, although this is rare. In Q fever endocarditis, the causative organism is Toxilla burneti, and there should be a history of animal contact. The aortic valve is usually affected, and this disease is usually associated with hepatitis, pneumonia, and valvula. May require lifelong antibiotic therapy sometimes. There is another group of organisms usually found in the upper respiratory tract, in the oropharyngeal commensals, which accounts for infective endocarditis in a very rare group of people, less than 5%. This group is known by the acronym HACHEC. Haemophilus, Aphrophilus, then Cardiobacterium hominis, Echinella colodens, and Kingella kingi. So these are the organisms which are acronymed as HACHEC. So these organisms or oropharyngeal commensals may sometimes produce infective endocarditis. Usually they are not so virulent, but it has to be kept in mind. The only problem is they require a prolonged culture so that the organisms can be found to be positive, and they may be resistant to the penicillins. Then Brucella also produces endocarditis associated with history of contact with animals and commonly affects the aortic valve. Rarely you may find infective endocarditis produced by yeast and fungi, Candida and Aspergillus. They may attack a normal valve or a prosthetic valve, usually in an immunocompromised person or those with indwelling IV catheters. Abscesses and emboli are common. The treatment is difficult in these people and you may require surgery, and it carries a high mortality. In these type of infective endocarditis, either by yeast and fungi, there may be concomitant bacterial superinfection. So that has to be kept in mind. So along with the antifungal drugs, antimicrobial drugs for bacteria may also have to be given. Now if we summarize these organisms, from where these organisms come into the bloodstream, because in the pathogenesis, the organisms invade the endocardium after it is entering through the bloodstream most of the time, except for sometimes post-operative or post-surgical. So from where are they coming? From the oral. The Streptococcus viridans comes from the oral or oropharyngeal areas as commensals, enter the bloodstream after a minor injury. Staphylococci epididymis or Staphylococcus aureus usually comes from the skin, either through an IV site, that is the most common, or after a surgery. The Hatchet group of organisms are commensals of the upper respiratory tract, and they have to enter the bloodstream. From the gastrointestinal tract, the Streptococcus gallolyticus can enter into the bloodstream and produce infective endocarditis by these organisms. And various enterococci from the genitourinary tract can enter the bloodstream with bacteremia and affect. And healthcare associated infections usually affect the native valves, are caused by Staphylococcus aureus and drug enterococci. So one has to remember what are the actual original sites from where these organisms originate, enter the bloodstream, and ultimately affect either the normal valve if the organisms are very virulent, or they usually affect a compromised valve, especially in subacute endocarditis. The clinical features of the disease. So as we have already said, it can be either an acute or more commonly a insidious subacute variety. However, there is considerable overlap between these two. It's not that the subacute will always remain subacute. It may turn into an acute phase at many times. So that has to be kept in mind. So this depends upon the type of the organism, whether it is a Streptococcus viridans, it's almost always a subacute variety, or Staphylococcus aureus, almost always an acute variety. The site of infection, where the infection is occurred, whether in a normal valve or in an abnormal valve. Prior antibiotic treatment. If prior antibiotic treatment has been started suboptimally, an acute infection may present as a subacute variety. And the presence of a valve or shunt prosthesis, if there is an implant inside the heart, either a valve or a prosthesis, then also the pattern of the infection may differ. Sometimes the subacute form may abruptly develop acute life-threatening complications such as an emboli or breakdown of a valve. So let's understand it this way. Supposing a patient has got a subacute bacterial endocarditis going on in a slow and smoldering way, suddenly there is an embolic episode. So that complication may be life-threatening. Or the valve which was affected might have broken down. So that will lead to an acute regurgitation of that particular valve. So these are acute life-threatening conditions which may complicate a subacute variety. So subacute does not mean that it's a smooth sailing problem. It may lead to acute life-threatening complications like in acute infective endocarditis. Now before we go to the clinical picture as such, what are the underlying pathophysiological basis for development of these particular features? You have the constitutional features in infective endocarditis with malaise, low-grade fever, anemia, lassitude. So these are because of the cytokines produced. Then the intracardiac structural damage will lead to heart failure, development of murmurs, arrhythmias, heart blocks. So these are the intracardiac damages which will lead to those type of clinical features, the cardiac specific clinical features. Then the embolization of vegetations into distant sites may lead to infarct or infection in different parts of the body, starting from infarction of the brain, the spleen, the kidneys, or infection in different sites of the body. Then bacteremia from that site. And another important area is these infections produce immune complexes. These immune complexes circulate in the body, lodge in different vital organs, and may lead to certain additional diseases like acute glomerulonephritis or presence of a rod spot in the eyes, or the Osler's nodes in the fingers. So these may be due to the immune complex mediated or immune response clinical features of the particular infective endocarditis. Now coming as such to the clinical features of subacute endocarditis. What are the features? The patient with a known congenital or a valvular heart disease who may develop a persistent fever, complaints of unusual tiredness, night sweats, weight loss, develops new signs of valve dysfunction or heart failure. So then you suspect that the person may be having an infective endocarditis on top of the already existing heart disease. Less commonly, these people suddenly comes with an embolic episode, either of the brain or of any peripheral arterial embolization. So then you suspect that this particular person has got an infective endocarditis. The other features which are not so common are purpura, petechial hemorrhage, and splinter hemorrhages in the nails, in the nail beds. The Osler's nodes, which we have just described, are not common, which is a painful bluish colored nodule, which is tender in the pulp of the fingers. Then digital clubbing or clubbing of the fingers is a late sign, but it is not an uncommon feature. It is quite common. Splenomegaly is a common feature in all subacute endocarditis. In coxilla infections, there is also hepatomegaly. So hepatosplenomegaly in a patient with subacute bacterial endocarditis, you suspect coxilla boniti infection. And there is a microscopic hematuria or non-visible hematuria. If you test the urine, you may find two things. One is a proteinuria because of the glomerulonephritis and RBCs. Sometimes these features may be present without a known valvular heart disease. So a person coming to you with a continuous low-grade fever, wasting, clubbing, splenomegaly, some features of acute glomerulonephritis, or on urine you may find microscopic hematuria or digital splinter hemorrhages. So in any of these, the underlying heart disease may be silent. So in these, whenever any of these are present, one should meticulously re-examine the person to look for any unrecognized or undetected existing heart disease, either by an echo or a thorough clinical examination. So that is usually done very commonly when you find a fever or low-grade fever coming with non-cardiac manifestations. The person does not respond properly within the first few days. You always think that infective endocarditis may be a possibility, always, although it is not a very common disease. What are the clinical features additionally for acute endocarditis? They present as severe febrile illness, not the low-grade indolent fever, but as severe, with prominent and changing heart murmurs and petechiae. The chronic stigmata of chronic endocarditis are usually absent, like the clubbing or low-grade or the anemia, splenomegaly. These are usually absent. Embolic episodes are much more common, and cardiac and renal failure may develop. Abscesses may be detected on echocardiography. Sometimes partially treated acute endocarditis often behaves like subacute endocarditis, but the treatment should be more vigorous, like in acute varieties. Now, the presentations of post-operative endocarditis may present as an unusual or unexplained fever in a patient who had a heart valve surgery. The infection usually involves the valving and may resemble either a subacute or an acute endocarditis, depending upon the virulence of the organisms. If it was a Staphylococcus epididymitis, then you may find a low-grade infection. If it was Staphylococcus aureus, you will find a florid infection. The morbidity and mortality are high, and a resurgery may be required. organisms are similar to native heart disease. If acute, then consider a coagulous negative staphylococcus, which may be quite common. To sum up the clinical features, you find fever in almost all of them. More than about 90% of them will have fever, chills and sweats. Constitutional features in up to 50%. Some of them will have body aches, myalgias. Another important thing is the heart murmur. Along with the fever, if you find a heart murmur, it's almost about 85-90% of these people, you suspect infective endocarditis. Worsening on a new regurgitant murmur is found in up to 50%. It's difficult to know because you must have examined the person earlier also, so that to know whether a murmur is increasing or a new murmur has come in. Because if you see the person for the first time, you will not know whether it is a new murmur or an old murmur. Clubbing, not so common, found in as well as splenomegaly, arterial emboli. Arterial emboli is more common in the acute varieties, splenomegaly clubbing is more in the chronic varieties. Neurological manifestations following an embolic episode to the brain, and peripheral manifestations like Oster's node, subungual or below the nail hemorrhages, Genevieve lesions, rot spot. So these are found in a varying range of 2 to 15%, and petechiae is also found sometimes in 10 to 40% of these people. So this is the usual plan of clinical presentation. So fever and heart murmurs or a changing heart murmur are quite common features. On top of that, you may find additional things depending upon whether it is an acute or a chronic, and some stigmata if it is a chronic variety of or a subacute variety of infective endocarditis. Among the investigations, the most important investigation is a blood culture, followed by echocardiogram, and ECG and chest X-ray will also help you. So blood cultures, you should take at least 3 sets of 2 bottles. That means 6 bottles should be taken, 1 aerobic, 1 anaerobic, separated by 2 hours, 1 hour, and from different sites over the first 24 hours. So when you start taking the blood cultures, you take 3 sets of 2 bottles of culture vials. Take 1 set at this moment. After 1 hour, you take another, and you take the third one within the 24 hours from 3 different sites. Then, and it should be preferably taken before you have started antibiotics. You need not wait for a fever to develop, that I will take the blood culture at the height of a fever. No, it is not necessary. But it should not be taken after antibiotic has been started, because that will drastically bring down the bacterial counts. So before you start antibiotics, from 3 different sites within the first 24 hours, take 3 sets of blood culture by all aseptic and antiseptic means, which is mandated for taking of blood culture. If the culture is negative after 48 hours or 2 to 3 days of time, you should take another 3 sets. So the blood culture should be 3 sets to 6 sets. Most of the time in hospitals, they are very complacent, and after sending 1 blood culture, people start the antibiotics and they are waiting for the cultures to come. Most of the time the cultures are negative. In most of the Indian studies, we find that the cultures are negative. In a significant percentage of infective endocarditis diagnosed clinically, including echo visitation, the cultures are negative. Whereas the same pattern in industrialized country, you find that the cultures are much more positive. One of the common reasons is our complacency during taking the culture. We don't take more than 1 culture. Taking 1 culture is enough, but it is not that. You have to take several cultures because the amount of bacteremia is not so high in these particular people. So you have to keep on targeting at different times so that you can at least pick up 1 culture. The first 2 specimens detects organisms usually in about 90% of culture positive cases. Now echocardiography is used for detecting and following the progress of the vegetation. So echocardiography, what are the things it can do? It can find out whether the heart has got any lesions inside, then detect the vegetation, and if you follow up the echo serially, you can find whether the vegetations have increased in size or they have regressed, and whether there are any abscess formations. So all these things can be detected by an echocardiogram. So this is an invariable or a very dependent tool. The usual transthoracic echoes can detect vegetations up to 2 to 4 millimeters in size. They can detect quite a small size. And transesophageal echocardiography, TOE, can detect vegetations as small as 1 millimeter. However, you always remember that even if you cannot detect vegetations in the echo, you cannot rule out the diagnosis of infective endocarditis. If you clinically suspect, if there is a virological or bacterial confirmation by culture, even if you miss the vegetation, you have to be assured that the person has got infective endocarditis. ECGs may detect AV valve block, AV blocks due to either an infarction or an emboli, and chest X-ray can help you to find out whether there is a heart failure or cardiomegaly. The usual blood parameters like a raised ESR, a CRP, a normochromic normocytic anemia, and leukocytosis are common, but may not be present always, not necessarily. In the urine, proteinuria because of acute glomerulonephritis and your microscopic hematuria. That means the person has a normally looking urine, colored urine, but there will be RBCs or microscopic examination. We call it microscopic hematuria. Summing up the laboratory findings, anemia is a very common feature like fever and heart murmurs. Leukocytosis is not that common. Microscopic hematuria may be found in up to 50%. The acute phase reactant, raised CRP, is also very common, more than 90%. Whereas ESR may not be elevated in all of them. Rheumatoid factor may be falsely elevated, circulating immune complexes and decreased serum complement may be found in a few. So circulating immune complexes, if you do the immunological test, is almost confirmatory. Anemia is found along with raised phase reactants, ESR and CRP in up to 90%. So it's quite common, these findings. But leukocytosis may not be so common. So this is the overall picture of a person with infective endocarditis. If you look, have a general survey of this individual with infective endocarditis. Head to toe. They may have embolic episodes in the brain, rot spot in the fundi, although rare, subconjunctival hemorrhages, rare, poor dentition or might have gone to a dentist, so the oral cavity problems, petechial hemorrhages in many sites, heart murmurs, up to 90%, conduction defect, heart failure. Hematuria quite common, Hostler's note here. Systemic emboli, nail infarcts, splenomegaly, petechial rash, digital clubbing, splinter hemorrhage, and loss of pulses because of emboli. So if you just look into this picture of an individual, you can understand what are the changes that might be occurring in a person with infective endocarditis, either an acute or a chronic. How to diagnose? We have the Duke's criteria, similar to the Jones criteria for rheumatic fever. It is a little bit difficult than the Jones criteria. Some major criteria and minor criteria. The major criteria are positive blood culture and echocardiographic evidence. Now, what are the major criteria? What are the blood culture? typical organisms in the two cultures. As I have said, in 90% you will find that the first two cultures will be positive. Persistent positive blood culture taken at more than 12 hours gap, which may not be typical organisms, remember. This is typical organism. If you found a person with features of subacute endocarditis and you found a Streptococcus viridans is positive in two cultures, you close your eyes and say this is subacute endocarditis. If you find a person with acute infective endocarditis features and you find that Staphylococcus is present in the first two cultures, close your eyes and say that this is present. But if you find that the organisms are present in multiple cultures, but they may not be the typical cultures, then also you have a positive blood culture, right? And 3 or more positive cultures with organisms which are not necessarily the typical ones. Then, what is the other major criterion? Positive echocardiac findings of vegetation or new valvular regurgitation. To new valvular regurgitation is difficult in our settings because we do not know whether the person had what is the earlier cardiac status of the individual, because we don't have a record of that individual most of the time in our developing country settings. Now, minor criteria: predisposing valvular or cardiac abnormalities, right? Intravenous drug use, misuse, a low-grade fever continuing, embolic episodes, vasculitic phenomena, blood cultures which are positive but are not satisfying the first 3 norms. These 3 norms are not being satisfied, but still, nevertheless, a blood culture is positive. And some suggestive echocardiographic findings, but not specific of vegetations. So these are the minor criteria. So we have some major criteria by blood culture and echo or even clinical, and some minor criteria by clinical, blood culture, history and echo. So based on these major and minor criteria, we now work out how to diagnose infective endocarditis. Patients with 2 major criteria. He has a positive organism in the first 2 cultures, and if there is a echo finding of vegetation, well, clear cut. Or 1 major and 3 minor. 1 of these major and 3 of these minor. So a positive 2 cultures 12 hours apart, together with that some valvular disease or a low-grade fever or maybe some embolic episodes, then also you know that the person has got. Or 5 minor criteria. That means out of these 7, 1, 2, 3, 4, 5, 6, 7, out of these 7, you should have 5 of them. So that is definite endocarditis. That means 2 major, 1 major plus 3 minor or 5 minor, then you say that the person has got definite endocarditis. Possible endocarditis when the person has got 1 major and 1 minor or 3 minor, any 3 minor or 1 major plus 1 minor, then we say that the person has got possible endocarditis. So this is always a clinical assumption that the person has got infective endocarditis or he or she does not have infective endocarditis, and the treatment is empirically started in most of the times, and we wait and look for the prognosis, because the treatment is also a prolonged treatment, at least minimum of 4 weeks to 6 weeks to 8 weeks of continuous intravenous antimicrobial treatment, usually in a hospital setup. So I think we will stop here for today. In the next class, we will finish up with the treatment of infective endocarditis.